Dr. Irgau, I believe we are live.
Great, wonderful.
Okay, we are live. Good afternoon. Sorry we are a couple minutes late. It does happen when your guest is always a practicing surgeon. So Dr. Irgau was able to make it right on time. So today is February 24th. This is American Surgery Center with the partnership of CHRIAS, Christiana Institute of Advanced Surgery. My name is Kemal. I have Dr. Isaias Irgau with me. Today we are going to discuss new topics for us. As our patients know by now, we do go by different topics, different sessions, making them small, short events so that it's easier to follow. So I'm going to ask Dr. Irgau to introduce himself, and then we'll start our session.
Thank you very much, Kemal. Hello, everybody. I'm Dr. Irgau. I am the president of CHRIAS, or Christiana Institute of Advanced Surgery. My specialty is weight loss surgery or bariatric surgery. I am part of a group of surgeons that specialize in this area, and we have been performing bariatric surgery now for almost 20 years in our area, and our group really represents by far the most experienced group in bariatric surgery in our area. I'm very happy to be here at Kemal. Thank you.
All right, Dr. Irgau, thank you so much. So before we start, as Dr. Irgau mentioned, our group is the most experienced bariatric program that we run, not only in Delaware, but probably nationwide. So what we would like to actually talk about today is the resolution of comorbidities after bariatric surgery and how the bariatric surgery actually helps. Now, what's important from this process is having the expertise on your side. So more than 10,000 bariatric surgeries among 6 surgeons, over 2,000 in the last 3 years. And being the only surgery center with MBSA QIP certification, this makes us pretty unique in this setting of bariatric excellence on the surgery side. So patients should be able to trust what's going on. And other than Dr. Irgau, I have Dr. Gail Wynn, Dr. Peters, Dr. Singh, and Dr. Ibrahim on the bariatric side, and we have Dr. Wade on colorectal side. In fact, Dr. Wade is going to be my guest next Thursday, and we are going to start the colon cancer month events, and then there will be 2 of them next month. And then also our dietitians, part of our program is Amy, Beth, and Fran. They've been with us and with our patients, supporting what's going on with our patients for the longest time. Now, today, this is our volume 8. So what we want to do is kind of just introduce the comorbidities. We call comorbidities, but these are other illnesses, other diseases, other chronic problems that patients may have. So obesity is never by itself. It always comes with its own baggage. So you can say this in so many different ways. And what you'll hear us saying is comorbidities, but Dr. Irgau, you may want to use a different specific term. The 4 main ones that we focus on: diabetes, type 2 diabetes, hypertension, sleep apnea, sleep disorders, and high blood pressure are the 4 that we kind of focus on, but there are many others that actually does come to resolution. So Dr. Irgau, we are going to ask you to educate us on what patients would expect after the surgery. I did include our percentages from Dr. Wynn's presentation. Last time I did this with her. If you would like to use those, feel free.
Absolutely, absolutely. So essentially, as you said, Kemal, we talk about illnesses that go hand in hand with obesity. You have obesity, you have those illnesses. You don't have obesity, you don't have those illnesses. So we call them comorbidities. They go hand in hand with obesity. Now, doctors didn't always know this. In fact, if you look at the history of bariatric surgery, when the first pioneers of bariatric surgery were performing the first operations, we're talking back in the 70s and early 80s, really their main goal was to help people who were suffering from extensive types of obesity. So people who were weighing 400, 500, 600 pounds, because these people were totally incapacitated in their daily life because of the obesity. They could not walk. They could not take care of themselves personally, from a physical point of view, because of the burden of the weight. So because these people were having such a hard time losing weight by themselves, bariatric surgery, in the way it was performed at that time, was really geared to help them lose a fair amount of weight. And they were successful in that. But as bariatric surgery became a specialty on its own, what doctors have noticed was not only were they helping people to lose weight, but they were making people healthier, because many patients who suffered from obesity and came to have bariatric surgery ended up losing weight, but ended up not taking medications for type 2 diabetes, not having to take medications for high blood pressure, not having to be on a CPAP machine for sleep apnea, and their cholesterol level was improving, and many other illnesses were improving as well. So what we have noted really is that obesity is not only a question of extra weight, it's a question of extra unhealthiness. You become unhealthy by virtue of the weight, right? So the accumulation of excessive fat in our body doesn't only become a physical burden for us, but it becomes an issue that interferes with our metabolic health. We cannot control our blood sugar adequately, therefore we become diabetic. We cannot keep our blood pressure within healthy range, therefore we develop hypertension. And sleep apnea the same, and hyperlipidemia the same. So the modern bariatric surgeon looks at themselves not only as somebody who helps people just lose weight and make them thin, but really make them healthy, make them metabolically healthy, getting rid of illnesses that by themselves separately require different treatments. And that is why currently primary doctors are actually one of the biggest advocates of bariatric surgery, because they are tired of treating all these illnesses separately when they know that the primary focus is obesity itself. So when a patient presents to the primary care doctor, their body mass index is 45, and they are on medications for type 2 diabetes. They are on medications for high blood pressure. They have CPAP machine at nighttime. Their cholesterol level is high. They are suffering from urinary incontinence. They are suffering from psychological problems related to obesity. They have joint problems because of the obesity. They have back pain because of the obesity. They have constant headaches because of the obesity, right? Then, instead of having to address all these problems separately, the primary doctor understands clearly that getting rid of the obesity is the solution, and they refer their patients to bariatric surgery because they understand that. And when we return those patients to the care of the primary care doctors, they are no longer diabetic, or they are taking much less medication. They are no longer have high blood pressure, or they are taking less medication. They no longer have sleep apnea, and very often they no longer have many of the other illnesses. So when we talk about comorbidity, we talk about serious health-threatening and potentially life-threatening conditions that accompany the development of obesity. And that's why bariatric surgery has become so popular now, not only among patients, but also among other health givers as well.
So, Dr. Irgau, these four illnesses comes with bariatric morbid obesity in many cases. 83% of the diabetes, 52 to 92% of the hypertension, 74 to 98% sleep apnea, and 63% of the high blood pressure. These are resolutions, and the numbers are kind of, and I'm in the program for so many years, so numbers are kind of high. It's almost like a dream-ish numbers. Can you elaborate that a little bit? Are these real numbers, or are we making them up?
No, they are real numbers, Kemal. They are real numbers. Look, patients instinctively know that their blood pressure started to creep up when they put on weight. They instinctively know that their blood sugar started being out of control as their weight increased, right? So really, even when they try and lose weight temporarily by themselves with some diets, patients see improvement in this. So it's not just bariatric surgery, it's really the losing of that weight. Getting rid of that weight has a direct and powerful impact on those illnesses associated with obesity. So these are definitely real. One of the greatest stories bariatric surgeons talk about, Kemal, is that in some patients, type 2 diabetes, particularly after some procedures like gastric bypass, improves overnight. There were situations, I remember actually, Kemal, when we had patients coming to hospital to have gastric bypass, and they would be on insulin for their diabetes. We would do the operation. The next day, we would check their blood sugar. It's normal, and they're not taking any insulin. So they would go home without the insulin. They would go home with complete resolution of their diabetes. Now, this doesn't happen in everybody with an overnight resolution of diabetes. It does happen in some patients, particularly with powerful metabolic procedures like gastric bypass or the duodenal switch. But clearly, with any procedure that leads to significant weight loss, there is improvement, if not resolution of those conditions come out. It is really, and as I said, primary care doctors rave about this. I mean, they're not only happy to see their patients thinner, happier, less depressed when they are fit, when they've lost weight. Mm-hmm. They are happy to see them because they don't have to worry about their blood sugar or their blood pressure either.
Well, in many cases, Dr. Irgau, it's not just one person, one provider, one physician trying to do these things. And I think we expect a lot from the primary care, honestly, from the system-wise, the government, the state government, the federal government. Every time there's something that needs to be done, they want primary care. On the other side, when things are with the vaccination right now, so they took it out of the primary care. So now the reason I'm saying this is because this morning, you may remember, we have a patient in our case conference. So this is important because even for today's event, I have 3 patients that I want to kind of mention, not the names obviously, but I just picked randomly 3 patients from our schedule. And the way that I pick them is just looking at their 6 months follow-up after the surgery, just to see how much weight they lost. And I didn't cherry pick them. I just picked exactly random. I just, let's pick this one. And now, before I get to that, if you remember this morning with the case conference, number one, there were 12 people on our case conference. Mm-hmm. Dietitians, the facility, yourself, me, and our care managers and care coordinators. So that discipline is not something that you can see easily in any other places.
Absolutely.
Any of the hospital systems, you won't see that because we have run those hospital systems in the past, and we were limited. Now, why this is more important for us, I just want to make sure that people understand this is because this is it for us. This is our main expertise and main focus.
Yeah.
So, today we had, I think 4 cases there, 3 of them are bariatric. So in the hospital setting, they may have 25 surgeries and 3 of them are bariatric. So they are not missing, I think they're not focused on this, right? So, and sometimes when you are at a smaller scale with these, you do better.
Yeah,
and
no question.
This is our, niche in a way that when you have the most experienced surgeons with you, when you have the program that you already have established, we just build on that, the dream come true, like Tesla of the auto industry, right? So all of a sudden you have Tesla, and because we knew how to do the other cars before. Now, the patient that I want to mention has the A1C over 7. Mm-hmm. And they just had a recent checkup. Maybe I think it was October 2020. Mm-hmm. The interesting part of that patient was they were given the order, A1C order, but they did not complete it. So, however, when we give the order for A1C, they complete it. Now, their A1C in 2019, it was 5.6 or 5.7.
Yep.
And then today it's at 7.2. Now, Aetna now requires endoclearance for anything over 7. Now, it's one thing that we need to treat the obesity, but now we incorporated this patient with their primary care and then say, look, you have to manage the A1C. Now, maybe they weren't able to follow up. Maybe they did and patient didn't respond. So there are a lot of other issues that patient may not be responding. But when you approach it from different angles, then you are able to helping the patient at a great level. So
Absolutely.
This is like an extremely important point that I want to make sure that we make it very clear. So we are not just treating the obesity.
Right.
So now, Dr. Irgau, we mentioned the 4 illnesses, but I also see heart problems and cancer. And I do have this other diagram that we used to have in our webinars. And because it's kind of too much going on there, I was trying to show this less, but I will leave that up to you. Now, can you talk about the other illnesses as well?
Yeah. I like this poster. Actually, it's a poster from the Cleveland Clinic. It's one of my favorites, and you are absolutely right. We use it in our educational seminars as well. Essentially, it shows the human body and the different organ systems that are affected by obesity. And you see so many disease states that are directly related to obesity. In other words, if you took obesity away from this person depicted in this diagram, you would take away all the other illnesses as well. So whether it's problems related to headache and migraines, psychological problems like depression or anxiety, something called pseudomotor cerebri, which is related to increased intracranial pressure related to obesity, obviously sleep apnea, pulmonary problems like asthma, heart problems, as you mentioned, the cardiovascular disease and hypertension, gastrointestinal problems like heartburn or reflux, urinary problems like leaking urine involuntarily, and this happens as obesity increases, problems with the joints, right, in terms of having degeneration of the joints or pain from joints, something related to poor circulation of the blood in the legs, which leads to something called venous stasis and swelling of the legs, problems related to infertility in young women, of course, metabolic problems like type 2 diabetes, non-alcoholic fatty liver disease. For instance, let's take liver disease, Kemal. It is interesting that as obesity increases in a person, the accumulation of fat in the liver increases as well, leading actually to an illness of the liver that can develop into cirrhosis. Cirrhosis is something that occurs in late stages of liver disease, for instance, from too much alcohol, medications, or a viral illness. And yet, in the United States, due to the increased level of obesity, the number one reason for cirrhosis in this country has become non-alcoholic fatty liver disease. A condition caused by obesity on the liver becomes the most common reason for very severe disease of the liver. So as you mentioned, yes, those 4 illnesses are the ones that we mentioned because we see them commonly, but there is no organ system that has been spared. And the other thing we know now is that with obesity, there is an increased risk of several types of cancers as well. Not to mention the fact that if you look at life expectancy, in other words, how long a person is expected to live, right, based on many factors, when the body mass index starts to climb up, as obesity goes up, as the weight of the person goes up, their life expectancy starts to decrease as well, in close correlation. So not only is a person living an unhealthy life when they have obesity, but also the chances of them completing their life expectancy is less. So they are likely to die earlier as well. So mortality becomes a problem caused by obesity as well.
So this, again, is very powerful in many ways. Now, I was trying to kind of help you with the drawings.
With the diagrams, yeah, I saw that. Yeah.
Something that's kind of in the middle of our body and how many different impacts it can have in different parts of our bodies. So it's pretty amazing, right? So
absolutely.
Now,
absolutely.
I have 3 patients that these are in the last 12 months. Patient with 238 pounds, starting 226 and 286. Of course, they're with their height, they have different, BMIs. But their average first 6 months weight loss was 20% already. That's not like in any way that we, again, I randomize data. But even if you don't randomize it, when you're averaging it out of 100 patients, that's still 20% minimum.
Yeah.
So, and these patients do have these problems, these illnesses, and then they live with these illnesses. It's the quality of life. It's expensive.
Of course. Very.
Right. So,
very.
And with all together, we still have some struggles with some of our patients or some patients who may want to sign up, but they are kind of worried about those. What can we tell for those patients to do? So how can we actually help them to get into the program?
So key is education, Kemal, right? Education, getting it from the right source. Now we know that, when patients come to me and say, I've struggled with weight, for the last 20 years, for most of my life. I've tried all diets known to man. I've done all different things and I lose weight and the weight comes back. And now it comes back, at higher levels, but also I have developed all this illness over the years. What is the best option for me? What I say clearly to patients is that each option that we have for bariatric surgery has value, right? The only option that is not acceptable nowadays is to do nothing. In other words, not to really accept that bariatric surgery is a very powerful and effective form of treatment for such a devastating disease. That is a problem. And that's where we have to educate people. Now, because bariatric surgery is surgery, obviously the first thing that people think about is when it's a surgery, they have apprehension, they have concerns, right? Because the immediate impact of surgery, the immediate potential complications of surgery are the ones that jump into their mind first, right? But we have to help them really balance the potential immediate complications of surgery with the long-term complications of obesity. And that type of balance, that type of assessment is not easy. And that's why it takes a while for people to decide to have bariatric surgery. The first time they hear about it, they actually reject the idea. On average, I think it takes about 1.5 to 2 years before patients really realize that bariatric surgery is a very important option for them. So education is what we have to do, not only educating our patients, but also continue to educate all healthcare providers for them to really not sit and watch a person increase their weight year after year after year without mentioning bariatric surgery as an option for them. That's what we have to do. And I think we're doing a great job because there is much more awareness. Sessions like this organized by yourself, Kemal, are extremely important because they really bring the discussions to the forefront, really, and people can understand and follow different aspects of bariatric surgery that they may not have thought of. So much so that, Kemal, I actually recommend the sessions for patients who are already even in the process within our practice. I tell them, look, you're coming to me to get information. You have questions for me. I'm answering those questions, but you might find that by attending these sessions, a question that didn't come up to you may be answered in those sessions. So
honestly, even though I'm conducting this with you, Dr. Irgau, I learn new stuff every time I prepare for this. Sometimes, because we just do it, maybe the attention is a little bit different. Yep. So when you are just doing it, so it's not connected with the meaningful way of, oh, well, this is what it is. Like the image that I shared earlier, sometimes we just don't even share that with our care coordinators because we are focusing on the 4 main comorbidities, illnesses. But I think the best part of what we do now is this is now available for patients for them to watch this at home.
Absolutely.
We still publish our webinars from Tuesday, and we do those webinars twice a month. Our live sessions every Wednesday. bariatric support group once first Tuesday of the month. And now, and I still get different questions from patients, from our team. Dr. Irgau, one of the questions that I would like to address is, what's the heaviest weight, like the BMI level, for patient can actually get the surgery at ASC? If you would like to answer that.
Absolutely. So at the ASC, we go generally by the body mass index. So we have two different limitations for males and females. This is based on the guidelines that we have from the American Society of Metabolic and Bariatric Surgery. And we say that the body mass index, the upper limit for the surgery center is 60 kilograms per meter square. That's BMI of 60 or below for females, and a BMI of 55 or below for males. Those are the guidelines that we're following. Now, depending on the height of the person, obviously, for a person to have a BMI of 60, the weight might be, 350, or it could be 420, depending on what the height of the person is. So currently, we are going it by a body mass index. And what we have found, Kemal, is that in our preparation period, actually, many patients who come to us even with higher body mass indices, higher than this, end up actually losing a fair amount of weight as they continue through the process, so their body mass index falls within the limits and guidelines that we have.
Like the last two examples that I remember, Dr. Irgau, 72 BMI started, and then she completed her process, and then 69 was another one. And we have someone right now with 69 BMI, but in 3 weeks, she came down to 66, and we are going to bring her down to 60. So although our limit is 60 BMI, we do have patients who are starting with higher. And then someone who may be starting at 52, 53, or 47, we still get them to lose weight throughout the process. So that's actually important for patients to remember. Now, these, as I mentioned, these events that we have, we share them on our YouTube channels, but now this became part of our routine. Every week we have these events, but if you miss them on our YouTube channels, they are nicely organized. And it would be great if, we also use these for as part of our patient education for people who are in the program. So I think this is really important for us to access to as many patients that we can, and being accessible to them is kind of like our goal. Now, Dr. I think that's all I have for from today. I don't know if you want to add anything before we close.
Absolutely. So, I mean, I think, it was very important for you to have brought this issue of the fact that we're not just weight loss surgeons. We're not here just to count the pounds coming down, although we know that is critically important in the minds of our patients. But really, we are making a major difference in really changing the health profile of a person who comes with diabetes, high blood pressure, sleep apnea, hyperlipidemia, or high cholesterol, 6 months, 8 months after their surgery will have been freed from many of those illnesses. And that's really for one treatment to be able to achieve all these multiple goals is really remarkable in medicine.
Well, again, thank you so much for joining me. I'm going to just check with Tanner if there are any questions that we didn't address. He's telling me we are okay. We'll be back next week at 3 p.m. Next week, we'll have another event on Thursday from CHRIAS and Surgery Center for Colon Cancer Month. And anyone who may be dealing with those types of issues, hopefully you're not, but if you do, Dr. Sachin Vaid will be with me. Tonight we have our diabetes event. Patients with diabetes, there's an event at 7 p.m. That's from United Medical ACO. There are so many different events. So if you don't watch your Netflix shows, you can actually watch us. We'll try to make it more fun for our patients. So Dr. Irgau, thank you so much again, and we'll see you.
Thank you, Kemal.
Thank you.
Stay safe, everybody. Bye-bye.